All right, good morning, everyone. My name is Guillermo Valladares. I'm a partner at Frier Levitt. We are a boutique healthcare law firm with over 40 attorneys. We specialize in many different areas of healthcare and life sciences work. Today's presentation, less is more, pitfalls scripted charting from a payment perspective, is something that anyone and everyone in healthcare can take from. What you're going to hear today is a combination of two very important aspects of charting, documenting, and billing. One is James Tudor of Healthcare Compliance Network, who has over 30 years of experience in this field. He has helped to create compliance plans for hospitals and also helped, single provider practices, solo practitioners through audits, overpayment demands, appeals, compliance plans, corrective action plans. His breadth of experience and the sophistication and size of his clientele run the gamut. So we are very happy that he's able to join us today to talk about the aspects of documentation, coding, how to stay off the radar, how to get the most money without having to also pay it back. Abdul Roberts of Frier Levitt, he works in our department, healthcare insurance department. He assists physicians, particularly with audit defense and everything that comes as a result of an audit. Many times something will start off seeming like it's a routine audit, like a prepayment review. You're being asked to send in records, and after they review the records, they'll pay you. What they don't tell you is that sometimes some of those audits, like a prepayment review, which Abdul will touch upon later, are really the gateway to an overpayment demand with an extrapolation. It's very important that you pay attention, who's sending you the letters. Abdul will go over the who, what, and when that you have to look at in these letters that you get from insurance companies, from investigators, to really triage it and determine what's important. So before I turn it over to them, I just want to highlight that this presentation comes about as a result of a article that was co-authored by Abdul and Jim, and it was featured already in Medical Economics and Urology Times. We can provide anyone who is viewing this webinar with a copy of the articles. I will turn it over now to Abdul Roberts, and please pay attention. This is something where I think everyone can learn about both how to keep the money that you are working so hard to earn, and at the same time, learning a couple of tricks along the way to earn the most money. Abdul, you take over.
Thank you very much, Guillermo, for that resounding introduction. So for many of the people that will be either listening or in attendance for the presentation, either a provider or an individual that is responsible for the billing of services that have been rendered. In the field that Jim and I often concentrate our time, we recognize the valuable resource that electronic medical records have become for providers and for those who assist in the billing of those services. For those who have practiced for many years, you've experienced the transition from what was paper charts to electronic charts, and in the amount of information that you would come to expect needs to be in those documentations to support the medical necessity for the services that you've rendered. With that transition, we've also noticed that auditors have begun to take a different approach in reviewing the documentation. And when you think about billing, that's ultimately where you need to start the conversation about billing appropriately, is in the documentation for the services that are being rendered during the encounter with your patient. So as Jim and I go through this presentation today, we really want to present this information in a way that is relatable, and you guys will be able to use this in your practice going forward. So think of it this way. You just received a letter from an insurance company for services you billed and completed maybe 2 months ago. The letter reads something like this. We've completed a review of the records underlying the services for this claim, and found that the document is insufficient to support the medical necessity for these claims. How did we get here? what went wrong? And that is why we think this presentation will ultimately be the most very valuable. And that's why we came with less is more, because a lot of times what documentation issues are being presented now is what has become counterintuitive to what you thought you needed in those notes. So how do we get there, Jim?
Well, thank you, Abdul. That's a perfect segue into how I wanted to start my piece of this, which is to talk about the coding creed. And of course, if you're a coder, provider, and I'm sure you, Abdul, are quite familiar with what I'm about to unveil, but on page 1 of the Coding Bible, it says not documented, not done. That has been ingrained, deeply ingrained into our brains over the course of the last, 20, 30 years. And it seems that the dynamic has changed. A lot of that may have to do with the EMR, and a lot of it has to do with some, let's call them preconceived notions, I feel, that are harbored by a lot of the insurance company investigators, as evidenced by the quote I'm about to reveal. And my question is, after hearing this quote, how did we get from not documented, not done, to just because it is documented doesn't mean it was done? And when this was actually expressed to us by an investigator from a major carrier that we work with, and he was referring to the integrity of documentation, which at times, under his impression, is questionable based on many factors, but for the most part, it's the EMR which facilitates ease of capture of all of the billing elements and coding elements that are so important. And when I mention preconceived notion, usually these, if you're subject to an audit by the insurance company, it usually emanated from a process of reviewing billing distribution by code. Too much of anything is not good, and that certainly holds true when it comes to billing and coding. So you build too many 99214s or too many modifier 25s, or maybe it's the impossible day scenario where they look at the average times associated with your codes and say there just simply isn't enough hours in the day to do this work. And I think that the assumption is if you're an outlier, there must be something wrong. And if there's something wrong, that is very likely going to be evidenced by, various factors revealed in your charts. And I think knowing that, is something that's, forever on the back of their minds. And it really kind of changes the dynamic for us in the coding and billing compliance space, because again, we're taught right from day one to assume that something recorded in the chart is legal authentication for an attestation to the fact that that particular service was done and those conditions that are documented exist and were evaluated. But that, apparently is no longer the case. And again, if you already are an outlier, there seems to be a thought that there has to be something wrong here, which, is quite frankly offensive to many providers, the vast majority of which are really just trying to understand the billing and coding rules, which can be tricky, gray, obscure, ambiguous, around every corner, just trying to get a handle on that and trying to create a template that facilitates capture of all the information. 99.9% of all providers I've met over those 30 years are not intentionally trying to commit any version of fraud whatsoever. They're just trying to get it right. They want to get it right in, this particular mindset, I feel, Abdul, is abundantly unhelpful, if you know what I mean.
So, Jim, if I may ask, you mentioned that it's documented, but I mean, they're being taught to be documented. So what about how providers are using the EMRs and documenting these is starting to cause confusion with these auditors? Is it there's too much information? What's really getting these auditors kind of like in a stink with these documents?
So it's too much information. There are a couple of things. It's the volume of information, which at times appears to be disproportionate to the presenting problem, let's say. So a patient comes in with a simple, URI, and there's, 5 pages of EMR note. Another thing that, and I'll talk more about this, is cloning. When there's entries in a chart which are exactly the same as previous entries, and over the course of time they're not edited. There's a lot of ways, and really what it comes down to as far as avoiding that situation is 2 things. First one is edit. Make sure that after you close out, before you close out and finalize your progress note, that all of the information done in that particular encounter, documented, was actually done. If there's any deviations, be it right down to, the med list and what was prescribed, what was done, the review of systems, the physical exam, any of that that wasn't done or wasn't, is inappropriately expressed based on the template in relation to that encounter should be edited. I think that that's, extremely important. And the other thing to watch out for are things like spelling mistakes. It's obviously we all do that, but there are instances where, we found audits where a provider had carried forward information from previous notes, including an entry that was misspelled. So when the payer sees that repeatedly through the note, that's a huge red flag for them that there was some degree of cloning involved. The spelling mistake that you wouldn't expect to keep recurring does in fact recur throughout Mary Smith's chart, sequentially over X number of service dates. So, really just, the editing is by far and away the important thing to bear in mind. And I understand the reason why, we are where we are, because, the guidelines for coding and billing, as I've mentioned, remain, to this day, despite some very significant changes which occurred about a year ago, the guidelines still remain rather, gray and fuzzy in many respects. Everything seems to beg further definition. When you've got that definition, there's another sub-definition which is required to further explain, excuse me, the terms and conditions upon which a particular coding provision is applied. And I think providers are very frustrated with that. It's like, I can't be expected to remember, how many review of systems I need for a level 4 code, and how many exam elements for a level 5, and how many data points do I need. It's just, the providers are there to take care of the patients, and they really, it's difficult for them. As a coder, you're thinking these are, extremely bright individuals, and I should be able to hand them a 57-page document with the E&M guidelines, and they can put it under their pillow at night and absorb the information. They're bright, they're smart, they should be able to get that right without, too much heavy lifting. But really, there's just so much going on with it, and I think that the inclination has always been to really, I won't say always, but in recent memory, i.e. the last 10, 15 years, the tendency is to, excuse me, really put too much information in the note. And this was an actual quote by a provider who said, I hear what you're saying, I missed this and that, and I hear what you're saying about payers are looking in a different direction on all this nowadays, but I'd still rather have too much in my note than not enough. If there are 5 bullet points I need to hit on, I want all 5 bullet points in my note. 4 of them is not going to do. That one could be could end up resulting in a take back or a down code or something like that. So, I just want to make sure that, I'm good in that regard, if that makes sense, Abdul.
Yeah. So, Jim, if I may ask, what's some As you mentioned, we've seen that when you have documents where there may be too much information, it can cloud an auditor's judgment. So what's some like low-hanging things, some easy things that auditors pick up on that you would consider like too much for, and that could increase their potential for an audit?
Well, and again, I'd mentioned, a disproportionate amount of information in there for the simple cold, how much, looking at the type of work that was done, does it seem reasonable? And you can think about it really almost from your own perspective as a patient. We've all gone to the doctor for a cold or something that's relatively self-limited and benign. And as an auditor, you're looking at a note and you're saying to yourself, last time I went in for a URI, they didn't do this whole head to toe physical exam, and they didn't ask me 20 questions here. It just seems that what I'm looking at really isn't appropriate, and you can make just kind of a knee-jerk judgment call like that. There may in fact be, in some instances, justification to do that degree of work if the patient is immune compromised or something along those lines that would necessitate a more thorough review. But I'm talking about just a straight, relatively simple URI type of situation that has, 5 pages of documentation. I think that's, a tip off right there, a major tip off. The other thing would be, the cloning and the carrying forward, like I had just mentioned, things like that, the misspellings that recur redundantly. Those are all red flags for an auditor. And it really just kind of, if there's even one mistake, we realize that, that perfection isn't really what's being asked of anyone. But if there is one mistake, human nature is to question, the remainder of the charts that you have to review. Say, well, if I saw, one instance where the patient couldn't provide a review of systems because they were nonverbal, but it says all systems were reviewed in negative. Once you see that, even, though it was very likely an innocuous mistake, once you see that, a switch is flipped and you kind of go on the alert as you proceed through the rest of the audit, raising an eyebrow at anything that looks like it may not have been legitimate, may not have been related to the problem, so it's just, at the end of the day, some good TLC, an extra 5-10 minutes proofreading your notes, is an excellent way of, going towards the ultimate goal, which is to bulletproof your notes, and as Guillermo said, make sure that you don't have to pay money back at the end of the day. We all want to maximize revenue, but what's the good of it if, you're going to end up on the radar and you're going to, in the event of an audit, you're going to end up getting dinged with a huge overpayment demand. It's just, it's not worth it. And it all can be fixed with, a little TLC. And I think that the new changes to the guidelines, which we're about to get to, go a long way towards making it easier for providers. So speaking of too much information, the greater the volume of information found within a typical progress or procedure note, the greater the chances that something is going to conflict, something is going to be potentially irrelevant, outdated. So I already mentioned superfluous information. I'll give you an example of something that occurred in recent memory. I did an audit on a provider, and it was he customarily spent a lot of time with his patients before, during, and after the visit. And he had an attestation which essentially said something akin to, I spent 25 minutes between face-to-face visit with patient, reviewing the chart, ordering prescriptions and tests and whatnot. It was just a generic attestation. And it had the same time associated in every visit that I looked at. However, in those same progress notes, some of them included an entry within the assessment which completely conflicted with the attestation that was appearing at the bottom. So in other words, even though he consistently said 25 minutes were spent, in his impression, in the same progress note, he would say, I spent 22 minutes with this patient. I spent 18 minutes or whatever the case may be. So now you've got this potentially irreconcilable conflict embedded in the mindset of the auditor because they're seeing this throughout. And your inclination is to go with the more specific time rather than was 25 minutes exactly devoted to each one of these patients. You're naturally inclined to go with the other one, but you've really got a conflict that you take that to your supervisor and say, what should I do with this? And he's more likely going to say, this is something we can't work with. It's a zero. Make them fight for it. And that kind of thing is what we just seem to see a lot more of now.
So Jim, you mentioned that in that example, you saw that this time or this conflicting information appeared several times. How does that relate to cloning? How would you, in sense of how would an auditor take an approach with that information as it appears with cloning?
Yeah, so because the stock time attestation at the end of the note was exactly the same, that would be indicative of cloning. And it was probably, an innocent mistake. My guess is the provider, again, this particular provider is known to spend a lot of time talking with the patients. And when he got wind of some of the changes to the E&M guidelines from last year, he said, oh, well, I can, also count a lot of that, before and after time as well. And I think his intent was to really modify the canned attestation, but for whatever reason he didn't. Again, we all have, so many hours in the day, but it was clearly, the same entry that was either carried forward or it was more or less his standard. And, when taken into perspective with the modified, let's call it time statement found in his assessment, it just created, an issue that would be very difficult to work around if you're an auditor trying to justify, the amounts paid. And they were instances where the time did affect the code as well, because I know, Abdul, there's typical times, let's call them, that are associated with all the E&M codes. And depending on how much time is spent in total, that impacts the level that you bill. And many of those changes, did have an impact on the final bill code. So, again, my thought is, they're probably going to make that provider fight for it. So that's a perfect segue into cloning to talk about that in a little bit more detail. According to CMS, cloning is defined as multiple entries in a patient's record that are either exactly alike or similar to other entries in the patient's health record or another patient's health record. So you could have cloning from, one chart to another. It's essentially, a copy-paste operation. And according to a 2013 report by the OIG, and I'll just read this out right to you, when doctors, nurses, other clinicians copy-paste information but fail to update it or ensure accuracy, inaccurate information may enter the patient's medical record and inappropriate charges may be billed to patients and third-party healthcare payers, which is essentially, what we've been saying. Fail to update it or ensure accuracy. The TLC, the extra 5 to 10 minutes. A lot of providers are not doing that, and it's causing, tremendous issues, when they're audited. So it's not just a Medicare thing. I mean, this is something that we see, in fact, more often than not, it's not Medicare in our travels, Abdul, where we see, a payer cite cloning to some degree. And in fact, right here is a snapshot. We've obviously, created this to protect the innocent, but these are copies of actual overpayment demand and audit report correspondences received by the practices. And this is just a tiny sample of what we've seen over the last 3 to 5 years where, either it's an abstract finding according to the insurance company, which has rendered claims unpayable, or they've seen enough of it throughout the audit sample so as they feel the integrity of the documentation may be compromised. And it's, it's the same type of thing reworded, time after time, which is to say, you can't do this, folks. There has to be, some degree of patient specificity, let's call it, or encounter specificity, maybe better to say, to the documentation. They feel that if it's just the same, if you look at Mary Smith's chart from service date number 1 through service date number 15, and there's very little to no variation between visit 1 and visit number 15, how can they justify the medical necessity of those services that transpired in the interim? It's a tough call.
And so, Jim, I'll just add, when you mentioned that the integrity of a document can be questioned. And when you get to that point with the auditor, I think you would agree it's a significant uphill battle at that point, to get the auditor back on the side of the provider, understanding what the provider is actually doing. And sometimes the consequences of that question of integrity is more far-reaching than, that simple letter or two for a medical records question. Would you agree with that, Jim?
Yeah, I mean, and the thing about it is, even, if you're with a group practice, they could potentially look at a provider who's cloning, saying, you know what, this group generates a lot of claim disbursements, and maybe we should take a look at the rest of the group to make sure that they're all not, following, the same tutelage, the same, following the principles associated with documentation. It isn't the same amongst everybody, because it's a potential gold mine for taking money back, to say, well, everybody here is, designed their templates the same way, they're using them the same way, they receive the same education, maybe they have received education from, a biller or coder, outside source that's basically told them, it's okay to do this. It really just opens the floodgates potentially, which is something that you definitely want to avoid. It's all avoidable. It's all avoidable. And fortunately, a lot of the changes that have been made, before we get to some of the things that have a very significant impact, we already talked about, how the medical necessity can be compromised. If there's no medical necessity, there's no reimbursement. This is a Medicare thing, and everybody who follows, some even remotely resembling version of Medicare guidelines says if it's not medically necessary, we can't pay these claims. And that can result on, to not just the overpayment associated with the cases in question, i.e. the audit sample, but possible extrapolation. So they can look and say, you know what, this audit was triggered by too many level 4 visits. We did an audit of 50 charts and found that we overpaid you $2,500 on those level 4 visits we looked at. And by the way, it looks like proportionately speaking, you've been billing level 4s at the same rate going back the last 3 years. So we can surmise, based on the chart audit results, that we've overpaid you. And this is where, the 6-figure overpayment demand comes in, which often is challengeable, and we'll get to that. But, and so there's also the potential for civil penalties, criminal exposure. Again, I've seen very, very few instances where, a provider was, intentionally trying to commit fraud. Insofar as I can tell, over the course of 30 years, literally just a handful come to mind. But that potential is out there. And in fact, in the state of New Jersey, they have to report you to the Department of Insurance if an audit reveals a pattern of overpayments. And this is reported before you've even had a chance to contest the findings. Automatically, and then of course you can contest the findings, and make a dent in that accusation, but it's assumed that if there is billing inaccuracies, that it constitutes a very liberal interpretation of the definition of fraud in New Jersey, Abdul. So
and I think what you just mentioned there is an important point that is a good segue to something that Guillermo mentioned earlier, and that's what is come what has been developed is what we know as a prepayment review. So, as Jim has just mentioned, these recoupments or this allegation of cloning or too much information, it can have a big price when it comes down to the reimbursement of these claims. And sometimes, as Jim has mentioned, you don't even know that there's an allegation of cloning until it's been reported to the Medicaid Fraud Division or some other state agency. So I only say that to say that sometimes it's best that even when you receive the notice just for a medical records request, or if you're a little concerned, to get with an expert coder or with an attorney early on, because there may be some, the code, like someone like Jim may be able to pick up on, hey, there may be some cloning going on here that might get reported. And those types of reviews or audits that are prepayments can still lead to these extrapolations, which in New Jersey is back for 6 years, which can be a significant amount of money depending on the size of the practice, the amount of reimbursement that you get from a particular payer, and other factors. So I just wanted to add to that, to what Jim is saying, is that it's not always the findings that can indicate that, or it's not. You don't always want to wait until you get the statement, there's some inappropriate billing, or we believe there's some inappropriate billing. If you're concerned, take the steps to get with an expert coder like Jim, or contact an attorney or someone, just to help you identify, if nothing else, make your notes bulletproof like you want them to be.
Yeah, and I mean, the prepayment audit process is just, it's definitely something you want to avoid at all costs. It's basically, you have to submit your documentation before the payer will pay claims, which of course can be just as revealing of deficiencies as doing a post-payment review, but it also slows everything up. You really should have some process of validating the documentation, since you're, under the microscope. Having someone in your office or someone on the outside take a look at those claims before they're ultimately submitted, so that changes can be made. And it's just a whole time-consuming, expensive, onerous process, soup to nuts, that can result in these reportings, as you've said, Abdul. So fortunately, there's quite a bit that you can do. Some of those remedies we've already touched upon, but one thing that we haven't gone into a lot of detail on thus far are the new coding guidelines from that went into effect January 1st, 2021 for evaluation and management, or E&M, office visit codes. Now, it's only the office visit codes and the outpatient clinic codes. So if you have you have a clinic in a hospital, and you're billing office visits, this would be the code set that you would use, the new and established patient code series. Those guidelines were, a good solid 25 years in the making. And essentially the biggest change here is there's no need to meet any requirements to quantify the history in the physical exam. And that is absolutely key. If we're talking about refining the notes into something that contains far less superfluous information, making your charts more readable, and just being able to be paid for a realistic progress note. I have an example that very concisely reflects that, is enormous. Now, when I say there's no need to quantify the history and exam anymore, that doesn't mean that you should not document any history and exam, because you certainly should. And it should definitely be any justifications which support the medical necessity for anything that you're doing or ordering. If your diagnosis is related to an item conveyed to you in the review of systems, then you want to put that positive review of systems element in your note. What you don't need to worry about is, do I have, quote, enough information in the history and exam to justify my code? Because historically, that's what you needed. It wasn't just about the complexity or the time, it was meeting those other key components, as they were called, which were determined to be equally important to the medical decision making. Long story short, so all of that went away, and we've done a pretty fair number of audits, both proactive and reactive over the course of the last year. And I'm still finding that there are a lot of providers who, are including, a pretty fair amount of extra, in elements that are no longer required to justify coding. And I understand that everybody's EMR is not created equally, and sometimes it's easier to make modifications than others. But from purely, wearing the coding goggles, as I'll show you in my example, the volume of information being recorded is no longer necessary to a very significant degree. So now it's all about either the medical decision-making aspect, which is the most intuitive part for a physician, or time. If you've have a patient that has a relatively straightforward problem, but they have, a ton of questions, and you're spending, a half hour, 45 minutes, it stands to reason that there should be some option of billing a higher level on the basis of time. And they made that easier, and they allow you to count not only that time spent directly with the patient, i.e. face-to-face counseling, but anything that you're doing before and after the encounter as well, as long as that work is done on the same calendar day that you saw the patient. If you, and I don't want to turn this into a full-on coding dissertation today, but if some of that work occurs either the day before the face-to-face visit or the day after, there are other ways of capturing that with prolonged service codes. But as far as the actual level for the office visit, it's based on everything you do for that patient on that particular day. It's not just a CMS thing. It's not, this is actually an AMA thing. This is hardwired into the CPT coding guidelines, these new rules. They have been accepted by Medicare and pretty much everybody else. And there's no longer any need, to really just pull too much with regard to that history and exam. Those were, the aspects which really seem to, amongst other things as well, but, those were the two, where I'd mentioned the volume of information would sometimes seem disproportionate, because you've got these, inventorial lists found within the progress note that sometimes are pulled in just for fear of not having enough information.
Yes, and Jim, so I'll before you show the example, I just wanted to hit on an undertone that you kind of put there when it comes to the use of the EMR. So with these new coding guidelines, what you're going to see is that over-reliance on your EMR can be a detriment at times. If you're continuing to include the information or the elements that are no longer necessary, and as Jim's going to hit on in a second here, not making the necessary edits, that over-reliance is what auditors are picking up on. And that's really where we are right now, and really why we're getting to this less is more, is that auditors are trying to they put you in this bind to use the EMR, but then they want to break you from the ease of carrying forward the information just by something as like copying and pasting.
What they really want, Abdul, is they want a patient-specific note. They are, the cloning has just gotten, in their estimation, too far out of hand, and they really just want to know what you did. You can be concise about it. This really started with the Patients Over Paperwork initiative from 2017 and culminated in the dramatic changes to the E&M coding guidelines. And I think you'll see across other aspects, there's talk about next year, maybe some of the E&M codes in other settings, such as inpatient codes, ED codes, E&M codes in the nursing facility will be subject to some of the same simplifications that took place in the office visit coding. And as far as what you make a good point about, being connected to less is more, this slide is actually less is more, personified in the sense that this is a concise, crisp, a brief progress note, a brief in comparison to, what we've all come to observe over the course of the last 20 years or so. It's a free text progress note that, and I'll tell you, this is not copy paste. This is me just simply creating this note based on things that I've seen, and it took less than 5 minutes to create this. There is no long review of systems. Is there a review of systems? Well, yeah, you could see no chest pain, shortness of breath. Is there an exam? It's only the most relevant parts of the exam. Maybe they did more than this, but there's no longer any need to document all of that work to help justify your code. It's a patient who has hypertension. It's not under control. In addition to making some changes, that the lifestyle changes, diet and exercise, they had a pretty significant discussion about it. This was a 30-minute visit here. So when I look at this, putting the coding goggles on, Abdul, I see this is a breath of fresh air. It doesn't have all of that, extensive information on the history and exam that really, isn't necessary anymore. It doesn't have, you can state that the medications were reviewed, as a physician, it's kind of assumed that you're going to review the medications as a healthcare practitioner. That just goes with the territory. There's no need to pull everything into the progress note. And it's again, there's no longer any need to meet those requirements on the history and exam, of which the review of medications was a part of, by the way. This does not appear to be a copy paste note in any way, shape, or form. It looks like 100% free text. And I'll tell you this, I think everything has come around really full circle on this, because when I got started in this business in the late 80s, the average progress note looked exactly like this. It was a good solid paragraph, maybe two, that took up half of a sheet of paper. They just basically said, here's what I did today. And that's what we've come back to when it comes to office visit coding. Now, I'm not suggesting that there aren't other types of coding, procedural coding, and things like annual wellness visits and chronic care management, which do require more granularity as far as hitting required elements. But I think the good news is, Abdul, this is, things are started, the tide is turned, and less is more is becoming the trend. More patient-specific documentation has become the trend. And when we're seeing notes like this, which are still fairly rare, presented to the insurance company, we're finding that these notes pass muster a lot easier than the 5 pages of URI note, as I label it. Everything is specific to the patient, unique to the visit. That's essentially what they're looking for. So we mentioned editing, is another major thing that goes a long way towards alleviating these headaches. Unedited notes are definitely a potential indicator of cloning. I'd already mentioned the spelling mistakes and things like that, but also the conflicts, like let's say that you did a free text HPI, which says this patient is in severe knee pain, but in your review of systems, it says no knee pain. That's something that the auditors jump on right away. Or I already mentioned the ROS, unobtainable, but got 10 systems and they were otherwise negative, things like that. Alert and oriented in the physical exam, but patient is nonverbal. That extra 10 minutes goes a long, long way towards really, truly bulletproofing those notes.
So Jim, I just want to kind of underscore something here. Are we telling people that you can't have templates at all, that templates are just bad now, or is it more than just having a template? Is it that editing is really the important portion of this?
Editing is the most important portion. It's okay to have a template. Templates will still, and again, when we're outside the realm of office visit E&M coding, there are many other, and I mentioned annual wellness visit. If you look at the guidelines for annual wellness visit, which is a Medicare well visit, there's a lot of very specific information which, is a complete endorsement for having a template in order to capture that information. But I think that there's, in the E&M coding realm, there's less reliance on needing that template for the purposes of billing than there ever was before. And there might be other reasons. There's a lot of reasons why, You could be using the EMR. There's quality measures. There's a lot of things that maybe a template, is the answer to. But strictly for the perspective of billing an office visit, there's a whole heck of a lot less reliance on it than ever before.
Yeah, and I'll just add one point. When you're talking about editing too, we're not only talking about from visit to visit, from patient to patient, right? We have some like in some of the patients or medical records you reviewed, or some of the clients we've had, we have some providers who are very niche. They deal in a very specific type of patient population, and might have similar symptoms amongst that patient population. But that editing, where that one patient doesn't have the dizziness that somebody else does, can go a long way. Would you agree with that, Jim?
Yeah, and we're not saying go through and rewire the verbiage in your progress notes just for the sake of making it look different. We're saying change what changes, because if you don't, eventually those trends are going to become evident in a chart review. So if you just change, like you said, that sometimes the patients are, there may be a subspecialty, or the patient, your patient panels are similar. It's like, hey guys, we see the same type of patient time after time, and we do the same type of thing time after time, and that's fine. Again, this isn't intended to be a creative writing exercise for anyone, but they do want there to be some uniqueness to your documentation. They know that even though there are those similarities, there are going to be some things that do change over the course of time. For example, you're a specialist and you document a history of present illness. Well, the history of present illness is what it is. It's what it sounds like. It's the history of that particular issue. Sometimes, the provider will kind of leave that in there without adding a whole lot to it. And we would recommend putting something like an interval history in there. The interval history should change, to some degree over the course of time. Since I last saw the patient, he reports his home blood pressures have been improving. You can have the whole history of hypertension chronicled, extensively, and there's no need to change it because it is what it is. It's the history. But there should be changes which are detailed. There should be some changes in the examination and the vital signs and all of that, of course. And those are the things that you want to pay attention to. And perfect segue here. We're ever so slightly ahead of ourselves here, Abdul. As I mentioned, there's no need to just rephrase it just for the sake of making it look different. But in my travels, patient-specific beats canned, almost 100% of time nowadays. Here's a canned attestation that looks similar to the one that I said I saw in the progress notes of that provider where there was a time discrepancy in there. So this is, 30 minutes face-to-face reviewing chart counseling and so forth, versus the attestation, which is similar to the one you saw in my realistic free text progress note that we just looked at here, where there's a little bit more in the way of detail. You don't want to skimp on the detail entirely, but just, you don't have to worry about, documenting anything fancy. I mean, this is literally how much time was spent, what did you talk about, put, maybe a sentence describing this in context. They're not following their regimen. They're not, exercising as much. There's many dietary indiscretions. How did you suggest that they change their behavior? Is there any changes to the medication? It doesn't take a lot of time to do this. And, fortunately, this is, a good, fairly solid level 4 example under the new guidelines based on, I should say, time or medical decision making in this particular example.
Yeah. So Jim, so oftentimes, like you mentioned, there's some time-based services, right? Whether it be counseling services or something like that. How would you say auditors take a note like the first one as compared to the second one when they're trying to evaluate whether or not the time portion of that element was met? Is more information, like the second note, is that better to fill in some of the gaps of the timing there? Or what have you seen with that?
So general rule is the greater the amount of time you spend, the more detail you should put into the note. because as I'd alluded to earlier, there are also prolonged service codes. So if you're spending an hour and a half total, you're billing 2 codes, not 1, to capture the full breadth of everything that was done in that particular day. But if you're going to bill for an hour and a half's worth of time, you should probably record more than you're seeing here on the screen right now. And I can't say that there's anything from CPT or CMS that says thou shalt document, 250 words for every 30 minutes of time. There isn't anything like that, but an auditor is going to want to get a pretty fair sense. If you're billing for an hour and a half, they're going to want a pretty detailed rendering as to how that time was spent. That would be not just the time spent face-to-face, but assumedly based on the type of physician work that is now capturable under the E&M coding. What did you do before and after? Did you also, spend time on the phone with the spouse, with the pharmacy, with the cardiologist? What did you do on that day that was so time consuming, making sure that you add to this, and again, I can't necessarily say how much you need to document because there is a fair degree of subjectivity to it, but you want to, the greater the time, the more information, you should put in there as a very general rule of thumb. What about other procedures, services outside the realm of E&M codes? Again, we're looking at editing really being the key here. Make sure that you pull out anything that wasn't done or things that were not done exactly as described in the template, not required for coding. We were involved with an audit not long ago, Abdul, for a provider who routinely provides injections, and we were told, look, it's the same type of injection I provide time after time. I use the same, dose, the same location specifically. Like there's commonalities, far more commonalities to what I do than there are variances. So how do you address that kind of situation? Because it just seems like, in many respects, there is nothing to change in a sense. And is there a way that you can preface your procedure note or insert, another form of validation to say, hey, look, folks, this is not this is a redundant service. So if you're seeing, some repetition here, it's because it's a repetitive treatment. Last performed on in this sample attestation, whatever the date was, and then you could say something akin to no changes in the patient's condition or describe what changes. It's basically you saying that, yes, this note is the same as the last time I provided this service for the patient. I'm aware of that, but this is not a situation where, we're just blindly copying, pasting without being mindful of the potential negative repercussions of it. We're saying this is a repetitive treatment. So it's a procedure. With a procedure, it's called a procedure because there are things that are common to it time after time after time. By inserting this layer of validation in there, which would be fairly easy to incorporate in an EMR, you're basically saying, don't ding this as cloning, folks. This is just the same thing that we do, a lot of repetitively. So quick summary of everything so far, and I think, a lot of these issues we've discussed are concentric to the EMR, making sure that how to use the templates, make sure you're editing the templates, be aware of what populates in your progress note for conflicts, like the provider who had the different time increments in there due to his time attestations. Know your EMR, exercise some due diligence at the end of the day, and try to go more in a direction of patient-specific notes. What did I specifically do? Just realistic, solid paragraph, maybe 2. Change what changes. Again, we're not suggesting that everything has to be 100%, pre-text, but, if there is some redundancy, make sure that you do change those things that changes. Consider implementing things like an interval HPI and do any necessary modifications. Understand the coding rules to an extent so that, you're aware of what needs to be documented. And an extension of that might be familiar. If you bill a particular type of procedure or test quite frequent, check to see if there's, amongst your top payers, if there's a medical policy, which maybe have some specific nuances in how to document the codes or document the medical necessity. And if you are ever audited, and folks, I hope you never are, but don't just, write a check and be done with it, because oftentimes, that's not the end of the story. By doing that, you've also admitted that there's something that was wrong. You're refunding them the amount they said was overpaid without any challenge whatsoever. And we find in the vast majority of cases we're involved with, that there is some point of contention, there is some gray area, there is something that, perhaps was, the result of a conservative, overly conservative assessment on the behalf of the auditor. Make sure that you fight those results, or at the very least, take a hard look at it, call somebody in to do an expert review. If you all have your own, CPC or expert in-house, make sure that they really go through and make sure that there's, validity to that. And if, there's any part of it which can be contested, fight the results, fight the good fight. Don't let them take money back that they're not legitimately entitled to recoup.
Yeah. So Jim, before we sum this up, I just want to emphasize that last bullet for you on fight the results, and just jump back quickly to some things that we've mentioned variously throughout the presentation here. It's not always waiting to the results, though. As we mentioned before, not all letters that you receive from payers are the same. There is this new prepayment review, which, as Jim has mentioned, is cumbersome, and at times it's beneficial to have an expert coder or somebody just come take a look at your notes, because they could be better. What Jim mentioned in a previous slide, one word could change the game for reimbursement, or one sentence. So fighting the results isn't always waiting until you receive an overpayment demand. Sometimes it means getting an expert coder or somebody involved when you first initially receive those medical records requests, because one or two claims innocuously being requested can lead to something bigger. And having someone on your side early on can prevent you from having this stark, overpayment demand that you did not want to experience to begin with.
Couldn't agree more. All right, I think we may have reached the end.
Yeah, so if there are any questions that you have as a result of the information in this presentation, please feel free to contact myself or Jim Tudor if you have concerns about any of the notices that you can receive from a payer. Again, please feel free to forward us that information, and we'll be sure to notify you and let you know if it's something to be concerned about or something you can just go forward and go about your business. But please be vigilant, as we said, and we appreciate the opportunity to relay this information to you.